afternoon, and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interests. If you have a question for the presenter, please hold until the Q&A segment. And if you're attending virtually, please enter your question into the Q&A section, and we'll be sure to ask for you. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Palwasha Khan. Dr. Khan is a current PGY3 internal medicine resident here at Northeast Georgia Health System. She holds a Bachelor's of Science in Kinesiology from the University of Calgary and a Master of Public Health from Lakehead University. She earned her medical degree from Ross University School of Medicine and is passionate about integrating clinical medicine with public health principles to improve patient outcomes. With interests spanning from real-time research with direct clinical applications to creative pursuits such as traveling and interior decorating, Dr. Khan brings a well-rounded perspective to her professional and personal life. Her commitment to evidence-based practice and curiosity for innovation drive her pursuit of excellence in healthcare delivery and patient-centered care. Join me in welcoming Dr. Khan.
Hi, everybody. Thank you for all being here. So today's topic is it time to retire the ARDSnet protocol? We're gonna evaluate APRV-TCAV and acute respiratory distress syndrome. So first and foremost, I have no financial relationships or conflict of interest to disclose. The presentation is intended for educational purposes only and does not endorse or promote any specific mechanical ventilator settings. So what is ARDS? So the objectives, objectives of today's talk are stated here. Of these, the most important ones are the second to fourth one. Describe key differences between APRV-TCAV and ARDSnet ventilation strategies. We're going to summarize the current evidence on patient outcomes with APRV-TCAV compared to the ARDSnet approach and explain the concept of repetitive alveolar collapse and expansion as it relates to the VILI vortex. So ARDS is a diffuse, acute, life-threatening inflammatory lung injury precipitated by multiple mechanisms, including severe trauma, hemorrhagic shock, pneumonia, etc., which initiates a SIRS response, increasing the microvascular permeability via disruption of the lung endothelium and epithelium, resulting in poor oxygenation and pulmonary edema. 190,000 Americans are diagnosed yearly. The mortality of ARDS is based on the severity of the disease, 27 for mild disease and up to 47 for severe diseases. So the diagnosis of ARDS is based on the following criteria seen here, known as the Berlin criteria. For lung injury to be classified as ARDS, it needs to be acute in onset, show bilateral lung infiltrates on chest radiograph or CT, which cannot be attributed to cardiac origin, and there needs to be a PaO2-FiO2 ratio of less than 300. Once this criteria is met, ARDS can be further subclassified as mild, moderate, and severe based on the PaO2 and FiO2 ratio, with less than 100 being severe ARDS. So pathophysiology of ARDS begins with injury to the lung, which activates alveolar macrophages. These macrophages go on to release cytokines and chemokines, which recruit and activate neutrophils. The neutrophils release inflammatory molecules to assist with pathogen killing. However, while doing so, they also injure the normally tight alveolar endothelial epithelial barrier consisting of adherent cell-cell contact and glycocalyx linings. The breach of the blood-gas barrier allows protein-rich fluid to accumulate in the distal airspace of the lung, where it inactivates pulmonary surfactant. In a healthy lung, pulmonary surfactant forms a complete monolayer, seen in blue here. As the edema expands, the monolayer is disrupted, causing surfactant deactivation. The inactivation of surfactant and the increased permeability allows pulmonary edema to move into the alveolar space, creating a cycle of expanding edema and injury. Surfactant inactivation in ARDS contributes to alveolar collapse, decreased lung compliance, and worsened gas exchange by allowing increased surface tension to develop within the alveoli. The hallmark of injury seen in ARDS is that it's not uniform. An early and still prevailing concept in ARDS, based on CT imaging, is that the lung becomes separated into two functionally distinct compartments along the gravitational axis. In gravitationally dependent regions where most edema accumulates and the most severe surfactant dysfunction occurs, alveoli and small airways collapse to form atelectic regions that do not participate in gas exchange. In non-dependent regions, which are largely devoid of edema, the parenchyma remains essentially normal and can be ventilated. This ventilated compartment or aerated tissue is reduced in volume compared to the whole lung, thus being referred to as the baby lung. However, as we will soon see, this may be oversimplifying a complex system. Currently, ARDS is managed using the protective lung approach, which involves low tidal volume and low plateau pressure, to protect the baby lung capable of gas exchange and avoid overdistension, which can cause volume trauma, while providing sufficient PEEP to prevent further lung collapse. In this way, the atelectic tissue is allowed to rest by remaining collapsed throughout most of the ventilatory cycle. The study that showed us this was the one shown here, referred to as the ARDSnet trial. So this was a multi-center randomized controlled trial across 10 university-associated hospitals from 1996 to 1999, and they enrolled a total of 861 patients. The population consisted of adult patients who had ARDS or acute lung injury, defined by PaO2 to FiO2 ratio of less than 300. They had bilateral infiltrates and no evidence of left atrial hypertension. The intervention involved dividing the patients into two groups: the traditional ventilated group and the low tidal volume group. The traditional ventilated group received a tidal volume of 12 milliliters per kilogram predicted body weight and a plateau pressure of less than 50. The low tidal volume group received a tidal volume of 6 milliliters per kilogram predicted body weight and a plateau pressure less than 30. The primary outcomes of the study was looking at mortality benefits, breathing without assistance, and the number of ventilator-free days over the first 28 days. So the trial was stopped early due to the significant benefits seen with low tidal volume ventilation. Key findings from the trial showed that a lung protective ventilation strategy, such as using 6 milliliters per kilogram predicted body weight and limiting plateau pressure to less than 30, reduced mortality and increased ventilator-free days in patients compared to traditional ventilation strategies. Secondary outcomes are listed here as well, which include more days without failure of non-pulmonary systems, reduction in inflammatory markers, and no significant difference in barotrauma. It would be natural then to expect that we would see a mortality benefit after the publication of this trial, right? But it's not working. Mortality remains unacceptably high at up to 47% and has shown little or no improvement since the ARDSnet trial, which was published in 2000. The top graph shows an initial decrease in mortality from 1981 to the early 1990s, but after that, mortality has largely stayed the same. The top chart stops at 2004, but the bottom study shows very little difference in mortality from 2014 to 2018. Recently published studies are also showing a lack of improvement in mortality, with some even suggesting an uptrend. So what's going on? In the next few slides, I will go over some of the reasons why we might not be seeing the mortality benefits that we expect from the ARDSnet approach. The first reason is due to the study showing exaggerated treatment benefits. In 2000, when the ARDSnet trial was published, standard of care in the ICU was to use between 9 and 12 tidal volume, with most ICUs using around 10. So the ARDSnet trial, interestingly enough, compared 6 milliliters per kilogram to 12 milliliters per kilogram tidal volume. As this standard was above what was normally used in the ICU, Deans et al. In 2005 decided to challenge the study and compared 2,587 patients that were eligible for the original study to those in the ARDSnet trial that received the 6 milliliter per kilogram tidal volume. I want to stress that these patients had the same characteristics as the original study participants and fit into the inclusion criteria, but were excluded for reasons listed in the image above, such as physician refusal, the patients were already a part of a different study, they were unable to consent, etc. These patients received a tidal volume of 10 milliliters per kilogram, which was the standard of care. This study showed that there was no difference in mortality between these two groups. Recent trials have also failed to find a benefit of low tidal volume ventilation when compared to pre-ARDSnet trial, tidal volume of 10 milliliters per kilogram predicted body weight. The next reason is because one size does not fit all. Deans and his colleagues went on to further look at the ARDSnet cohort based on their lung compliance at the time of initial randomization. They found that tidal volumes of 12 milliliters per kilogram were not always associated with increased mortality, nor were low tidal volumes always associated with lower mortality. In the patients with low pulmonary compliance, i.e. those that had stiffer lungs, when randomized to the low tidal volume group, demonstrated a significant improvement in mortality compared to those in the higher tidal volume group. However, the patients with high compliance demonstrated an increase in mortality when randomized to the low tidal volume group, and did actually better in the higher tidal volume groups. It seems then that lung approach or injury is not dictated solely by the tidal volume, but also on the extent of inflatable tissue indicated by a respiratory system compliance that receives that tidal volume. Clearly, a better personalized approach may be needed. This is another study that shows two different patients receiving the same tidal volume of 6 milliliters per kilogram can have tremendously different results. The green here is the atelectic tissue, and the blue is the aerated area or the baby lung. Although both these patients received the same tidal volume, the one on the right is showing severe ARDS compared to the one on the left. Another issue is the concept of the ventilator-induced lung injury vortex, coined by Marini and Gattattoni. These authors argue that although resting the collapsed lung sounds protective, long-term atelectasis results in more strain applied to the remaining normal tissue during ventilation, especially at the interface between healthy and atelectic alveoli. The strain on the surrounding alveoli caused by overdistension leads to localized injury, exacerbating surfactant dysfunction and causing further reduction in end expiratory lung volume, and loss of aerated tissue, driving the lung further into the VILI vortex. As stated in the last slide, the damage is mostly concentrated in areas between collapsed and open alveoli. The interface is particularly susceptible to stress failure because the alveolar walls are being bent towards the edema-filled alveolus, as can be seen in the animation here. Strain is defined as the change in size of a structure to an applied load. In mechanical ventilation, strain is the change in size of alveoli and alveolar ducts, and the applied load is the mechanically delivered tidal volume. When healthy alveoli receive tidal volume, the pressure received by one alveoli should match the pressure in the adjacent alveoli, essentially canceling out when a healthy alveoli is adjacent to a collapsed, essentially canceling out. But when a healthy alveoli is adjacent to a collapsed alveoli, suddenly the pressure in the open alveoli is no longer balanced, and this causes the open alveoli to expand and deform in such a way that the strain on the alveoli is quite significant, almost 2 to 4 times more than what was intended. For example, if the intention was to deliver 30 centimeters of plateau pressure, the actual pressure delivered in this particular area would be anywhere from 60 to 120. This concept of the expanding alveoli is called a stress multiplier and could be playing a role in the VILI vortex by initially causing microstrains, which go on to cause further damage. This is especially true in the presence of repetitive alveolar collapse and expansion, as seen with the current ventilator strategies. In this image, all alveoli should feel the same amount of pressure and remain stable. However, the alveoli surrounding the damaged alveoli are feeling more strain because they are being expanded towards the atelectic alveoli that is not able to expand and push back. With continued ventilation causing them to repeatedly collapse and expand, these alveoli may also get damaged and collapse, creating a ripple effect that will extend outward from the initial source. So this is just a different version of the previous video, again showing the strain felt by the alveoli adjacent to the collapsed alveoli, leading to stress multiplication and further damage. The next issue deals with permanent dysfunction and fibrosis. ARDS progresses through different phases, starting with alveolar capillary damage, a proliferative phase characterized by improved lung function and healing, and a final fibrotic phase signaling the end of the disease process. In the proliferative phase of ARDS, pathogens and damaged host cells are cleared from alveolar space, and the immune response is recalibrated to prioritize repair and restoration of normal function. This involves neutrophil apoptosis and regrowth of epithelium by differentiation of type 2 alveolar cells into type 1 cells. If the proliferative phase is impaired or prolonged, ongoing inflammation and fibrosis proliferation will impair alveolar clearance and functional recovery. Areas of atelectasis that remain collapsed, known as the collapse induration, can become permanently dysfunctional and fibrotic. Since the current ARDS ventilation approach is to rest the atelectic lung instead of trying to open it, the risk of the lung becoming fibrotic may increase. Atelectasis and loss of lung stretch is another issue. As just discussed, the continuous loss of aerated tissue and progression of atelectasis further shrinks perfusion surface area, causing hypercapnia and hypoxemia, resulting in higher FiO2 requirements, which can cause oxygen toxicity and absorption atelectasis, exacerbating all the problems associated with lung collapse. Atelectasis is also independently associated with loss of surfactant, causing further lung damage. This is because lung stretch during mechanical ventilation is needed to stimulate exogenous surfactant release by type 2 pneumocytes. So the current protective lung approach is constrained to ventilating an injured lung with heterogeneously distributed regions of collapse, since it does not attempt to reopen the lung. This heterogeneity, combined with low tidal volumes, further contributes to the progressive loss of aerated volume and drives the VILI vortex further, causing the problems we just went through. The addition of PEEP also does not prevent the derecruitment of lung regions due to the transience of the open lung compartment. So if atelectasis, instability, and collapse are the engines that drive progression of ARDS, the primary goal of any protective ventilation strategy should be to eliminate instability as soon as possible, minimize atelect trauma, and stabilize the lung by preventing repetitive alveolar collapse and expansion. Once the lung is stabilized, the next goal should be to reopen the lung gradually so that it may heal in a more natural state. And this should be allowed to slowly occur slowly and safely over hours or even days. Most importantly, it should be personalized. So time-controlled adaptive ventilation is a strategy that is designed to stabilize lung tissue at risk for repetitive alveolar collapse and expansion using the airway pressure release ventilation. TCAV utilizes a continuous positive airway pressure that is periodically interrupted by a brief release phase. The extended time at inspiration, combined with an inflate and break ratchet method, gradually reopens collapsed tissue while allowing the lung enough time for efficient CO2 removal without allowing derecruitment. This is equivalent to a system that allows motion in only one direction and prevents movement to slide back to the previous position, like a car handbrake or a ratchet. The next breath will start the cycle from the previous lung volume to achieve further recruitment and stabilization. This effectively establishes a time-controlled PEEP and expansion that is able to gradually open collapsed tissue. The precise timing of the release phase necessary to prevent repetitive alveolar collapse and expansion is based on the changes in the patient's respiratory compliance, and therefore TCAV is a personalized approach to ventilation, making it different from other methods and even other APRV parameters. So it's important to remember that APRV is a mode on the ventilator, and TCAV is the method that identifies specific parameters of that mode to achieve its desired effect. Just like ARDSnet is the method and it uses a volume assist control mode, this will become important later on. APRV is a pressure-controlled and time-cycled mode in which spontaneous breathing can occur throughout the breathing cycle, but it's important to note that there does not have to be spontaneous breathing, and you can use this mode even in a paralyzed and sedated patient. APRV has 4 settings to determine the inspiratory cycle or CPAP phase. These include the inspiratory pressure, or P high, and inspiratory time at the high pressure, T high. To determine the expiratory cycle or release phase, expiratory pressure, P low, and expiratory time at low pressures, T-low. Once set, these settings should be reviewed periodically, at least once every 12 hours, and more frequently when clinical conditions change or when certain events occur. This slide is just showing how APRV mode looks like on the ventilator set up using the TCAV method. The other image goes over how to set up APRV-TCAV and then how to optimize, stabilize, and wean the patient off. Notice the P-low is 0 and T-low is 75% of the predicted expiratory flow. More on this in the upcoming slides as I briefly go over how to set this mode correctly. So the initial P high is generally set to match the plateau pressure achieved by the conventional mode prior to transition. For patients who receive APRV immediately following intubation, consider using PO2 from ABG values where mild ARDS would set P high at 20 to 24 centimeters, moderate would be at 25 to 29, and severe would be 26 to 30. And in some patients with obesity and heavy chest wall weight, P high may need to be even higher. Ideally, you want the P high to maintain lung inflation along the steep portion of the pressure volume curve between functional residual capacity and total lung volume. Once initially set, P high can be titrated upwards or downwards by 1 to 2 centimeters at a time in response to change in lung volume and compliance to achieve minimal tidal volumes greater than 4 to 5 milliliters per kilogram predicted body weight. Imaging such as chest x-ray can be used to assess lung volumes by looking at the curvature of the diaphragm. The ideal location for adequate lung volumes is a dome-shaped diaphragm that is located in the mid-clavicular line. The initial T high in APRV may need to be less than 4 seconds to maintain the respiratory rate and tidal volume to that of the conventional ventilation mode used before transitioning. This is because APRV may initially drop minute ventilation, resulting in hypercapnia if the T high is set between 4 and 6 seconds. Since the lung has not yet recruited enough alveoli to sufficiently exchange CO2. To select the T high, calculate the current respiratory cycle time using 60 divided by respiratory rate, then subtract the set T low. As the lungs slowly begin to recruit more alveoli, the T high can be titrated upwards. Increasing the T high will lower the respiratory rate, but this does not negatively impact PaCO2, as the increased diffusion area with lung recruitment greatly accelerates gas exchange. As more lung units are recruited, the lung efficiency improves, lung stability increases, and more alveoli are maintained in a stable, inflated state. In APRV, P-low is the set level of external pressure applied during expiration. In the APRV-TCAV mode, P-low is best set at 0. This can sound alarming at first, but it's important to understand that P-low does not determine the end expiratory pressure. In other words, while the pressure on the machine may say 0, the pressure inside the lungs will not be 0. We know this because the flow is not 0, and for there to be flow out of the lung, there has to be some type of pressure differential. This means that although the driving pressure may look like they are 30 in the case of P high being 30 and P low being 0, at the micro level, the pressure may be much less because end expiratory pressure is determined by the interaction between the P high and T low, which does not allow complete expiration and collapse of the alveoli. Therefore, leave the P-low at 0, the lungs will be fine. T-low is one of the most critical and distinctive features of the TCAV method. Therefore, setting it correctly is very important. T-low is set based on lung mechanics and the patient's expiratory flow rate. It is set at the point where initial peak expiratory flow is at 75%. In other words, T-low equals the time it takes for the expiratory flow in a released breath to decay by 25%. In order to do this, start an initial T-low of 0.5 seconds for 1 to 3 breaths. Using the ventilator freeze waveform function, determine the peak expiratory flow rate. The T-low can then be adjusted so that the timed expiratory flow is 75% at the peak expiratory flow rate. So in this case here, this is the wave freeze mode. And this is the peak expiratory flow rate. So as you can see right now, T-low is set to 0.5, and clearly the breath has decayed more than 25%. So you can do it 2 ways. You can either eyeball it and say where the 75% would be, or you can say how long this is. So imagine if the peak expiratory flow rate was 100, then 100 times 0.75 would be 75. So you would want this value, this here, to be at 75. So you kind of play around with the ventilator mode until you get to 75, and that's now your T-low. The TCAV method personalizes and adapts the release phase, the T-low, according to the patient's lung physiology. An important concept to remember is that lung recoil forces are proportional to elastance of the respiratory system, and that a more elastic lung is a less compliant lung. Therefore, a healthy patient with a functioning pulmonary surfactant system will have a normal and expiratory lung volume, low lung recoil, low elastance, and therefore a compliant lung. As lungs get injured, such as ARDS, the lung compliance will fall, lung recoil will increase, and therefore elastance of the lung will increase, causing a more rapid expiratory flow, which reduces the duration of the T-low. As you can see in the image, a gradual expiratory flow results in a shallow slope. A shallow slope means a longer release phase and more exhaled volume and pressure loss. Increased exhale lung volume reduces time-controlled PEEP, i.e. the lungs need less pressure support to function and stay open. The ARDS patient with high lung recoil, however, has a rapid expiratory flow rate, which reduces the duration of the release phase. The shorter the release phase, the smaller the exhaled lung volume and the higher the time-controlled PEEP, i.e. their lungs need more pressure to stay open. Thus, the TCAV method matches tidal volume and time-controlled PEEP to lung pathophysiology, effectively controlling the delivered tidal volume in accordance with changes in respiratory compliance. So using time control of flow, we can directly regulate an expiratory lung volume instead of setting PEEP manually on the ventilator. Heterogeneous edema and loss of surfactant make the affected alveoli sticky. This means that the lung collapses relatively quickly once a threshold closing pressure is reached, but also require longer inspiratory time above the opening pressure to fully inflate, effectively making the lung both time and pressure dependent. And TCAV counterbalances these pathological changes by having an extended inspiratory time to allow for inflation in regions requiring longer time, and a brief release phase to prevent rapid collapse of lung units with a shorter expiratory time. Avoiding volume losses between inspiration and expiration is important because the retained lung volume produces a time-controlled PEEP even though P-low is 0, because the lung simply does not have sufficient time to fully depressurize. This is because the fluid that lines the air spaces must flow to the point of closure, which takes time depending on the volume and viscosity of the fluid, as well as the surface tension. Moreover, changes in airway pressure are not transmitted immediately to the distal lung regions due to the resistive pressure drop across conducting airways. This closing delay allows time to achieve the minute ventilation necessary for gas exchange without losing end expiratory lung volume. The lungs can be thought of as having a viscoelastic behavior of alveolar recruitment and derecruitment, described by using a spring and dashpot model. So during inspiration, the spring is rapidly stretched, whereas the object in the pot moves more slowly as fluid squeezes around it in response to the applied forces. The effect of this viscoelastic behavior is continual alveolar recruitment as long as inspiration is held. The viscoelastic behavior during expiration shows a rapid collapse of the spring and a much slower collapse of the dash in the pot. This is what is being shown in the open lung to time curve. Viscoelastic alveolar openings suggest that the longer inspiration is held, the more alveoli will be recruited, and that the shorter the expiratory time is, the fewer number of alveoli will be derecruited. Like the previous slide showed, the brief release phase controls the duration of passive exhalation. This regulates and retains an expiratory lung volume and exhaled lung volume, allowing for the direct control of lung volume changes between inspiration and expiration. This is why it's so important to keep T-low at 75% of the peak expiratory flow, because a T-low that is too long may decrease the end expiratory pressure, leading to derecruitment and atelectatic trauma, while a T-low that is too brief may cause overinflation and volume trauma. So as discussed, repetitive alveolar collapse and expansion during mechanical ventilation depend on both time as well as pressure. Forcibly reopening collapsed atelectic tissue takes significant pressure. In the ARD trial, a peak recruiting pressure of 50 was needed to open the atelectic lung. Thus, it's easy to imagine that over time, the process of unnatural rapid reopening and closing of the lung with current recruitment maneuvers strategies results in more tissue damage than if the lung was allowed to remain collapsed. Current strategies also do not provide the time that some alveoli may need to open. During TCAV, however, the lung spends most of its time exposed to the CPAP phase. Since recruitment of closed lung units depend on time as well as pressure, the longer the high pressure or CPAP phase is applied, the more lung tissues that can be recruited. In the image here, you can see that a PEEP of 5, very little alveoli recruited at inspiration. This improves at a PEEP of 16. However, between inspiration and expiration, there is quite a bit of derecruitment. We can imagine that repetitive ventilation would cause tissue damage here secondary to repetitive alveolar collapse and expansion. In APRV set at the correct mode, there is a lot more recruitment of the alveoli and very little difference between inspiration and expiration. So from this video here, it's clear that alveoli need to be opened slowly in small increments over extended periods of time to cause minimal tissue damage with each breath. So if you guys look here, this is going to take quite a long time to slowly push open. And even this alveoli took a little bit of time to get there. So there it goes. This image is showing macro and micro level imaging of percent alveolar recruitment over time and graphing it. As you can see, although most of the lung inflates within the first few seconds, the atelectic lung needs a little more time and nudging to do so. Remember, in TCAV, this new recruitment will not be lost, so the next cycle will begin here and continue to push the lung open more. So the pressure time integral describes the degree of pressure the respiratory system is exposed to over a given ventilator cycle. Due to TCAV's ability to finely regulate the time at the CPAP phase and the time during the release phase, APRV is able to precisely and independently regulate the pressure time integral according to the pathophysiology of the patient's respiratory system. The extended time during the CPAP P-high phase gives TCAV a significantly greater pressure time integral than the standard of care low tidal volume ventilation. A higher pressure time integral gives the entire respiratory system additional time to equilibrate the delivered inspiratory pressure. This means there is more time for the pressure to be distributed to the chest wall and distal air spaces to recruit more alveoli rather than being confined to only the more proximal airways. Using in vivo microscopy to visualize the alveoli of rat lungs with acute lung injury, TCAV recruited the greatest number of alveoli and improved alveolar surface area compared with conventional low tidal volume ventilation, despite positive unexpiratory pressure levels up to 24. The improvement in oxygenation is in part due to the alveolar recruitment. However, alveolar recruitment itself may not be sufficient to maintain oxygenation and prevent lung injury without sustained time-dependent alveolar stabilization. By preventing recurrent collapse and cyclic recruitment-derecruitment maneuvers, stress multipliers are reduced and lung-induced ventilation injury is avoided. The homogeneity and stability of the alveoli permits persistent alveolar recruitment with less energy transfers as compared to PEEP recruitment methods. This slide here shows that APRV, when properly set at APRV of 75%, has the least microstrain on alveolar airspace and the most number of recruited alveoli. So by using TCAV, it's possible that we are mimicking the alveoli of healthy lungs, which do not expand and collapse as we breathe. Rather, at the micro level, are extremely stable in size compared changing only about 5% between inspiration and expiration, much like as shown in the video. This is a lot different than the earlier videos we saw where rapid and repetitive alveolar collapse and expansion were propagating the VILI vortex further. So this is a microscopy slide of healthy alveoli in inspiration and expiration. As you can see, you can hardly notice a difference between the slides. So let's go back to the ARDSnet trial for just a minute. One of the arguments for why 6 milliliters per kilogram predicted body weight is better than 12 milliliters per kilogram predicted body weight is because at 6, you may not be giving enough pressure to the lung to even be able to do recruitment, de-recruitment maneuvers, which essentially is taking away microstrain on the alveoli, again highlighting the importance of microstrain and stress multipliers in ARDS. In this ARDS model, they compared transpulmonary and pleural pressures to time in both TCAV and low tidal volume ventilation. TCAV was associated with significantly greater plateau pressures as compared with low tidal volume, yet the two groups had statistically similar transpulmonary pressures. The majority of the greater plateau pressure in APRV was being sent towards the chest wall and not towards stressing the lung, leading to an increase in pleural pressure and a reduction in chest wall elastance. The strategy of distributing pressure to the chest wall, as well as a brief expiratory release time to minimize chest wall elastic recoil, represents a novel and exciting mechanism by which TCAV may be protective. By providing sufficient pressure to oppose the elevated intra-abdominal pressure associated with extrapulmonary ARDS, the volume pressure curve of the chest can be shifted back to the left, and diaphragm contraction and at end expiration can be increased. This is especially important because the diaphragm is an important regulator of expiration. Its expiratory activity seems to preserve lung volume and protect against lung collapse. The loss of diaphragmatic expiratory contraction during mechanical ventilation may be a contributing factor to unsuccessful respiratory support. So this is a slide showing improved inflammatory markers in APRV compared to other ventilator modes. As you can see, IL-6 and cytokines, which are both markers of inflammation, are reduced in APRV and are closer in comparison to the healthy lungs. These are some more graphs showing how alveoli ventilated with APRV may do better than the current method of ventilation. On the left here, APRV lungs showed a larger number of ECA adherents, which is a protein that helps glue cells together, especially epithelial cells, to maintain tissue integrity and barrier function. A larger number of ECA adherents may indicate that lung ventilated with APRV may undergo less damage or recover quicker. In other words, in the other graphs, there is more surfactant seen in APRV lungs than lungs ventilated via low tidal volume. Not shown here, but one study also showed that alpha-reglan, which is a marker of overdistension, does not increase in APRV ventilated lungs compared to low tidal volume lungs, again indicating overall healthier lungs. As we learned before, APRV has improved flow, and this improved flow also improves mucus movement and lymph out of the lung. So our understanding of the baby lung, or seeing alveoli as little grapes or balloons, may not be accurate. Microscopic analysis of alveoli showed that they are interconnected polygonal-shaped structures that share walls and interact with their neighbors. This interconnection and attachment could be why atelectasis trauma propagates and predisposes the lung to additional volume trauma by overdistending the adjacent open alveoli when the atelectic alveoli collapse during exhalation. In TCAV, the longer inspiratory time recruits more lung tissue without large transient increases in airway pressure and mechanical power. Once lung units begin to open, alveolar interdependence propagates aeration of adjacent collapsed regions, inflating more alveoli and starting the cycle of stabilization, reaeration, and homogenization. This stabilization is key to avoiding repetitive alveolar collapse and expansion with each expiration in order to halt the ventilator-induced lung injury vortex. You can imagine that in order to keep alveoli open, the most logical approach would be to maintain airway pressure above the highest closing pressure at all times. Raising PEEP to the necessary level in ARDS, however, is often not possible because closing capacity and the pressures to maintain the lung open can be substantially elevated. Moreover, conventional ventilation still requires sufficient driving pressure above PEEP to maintain adequate ventilations. So how is TCAV able to generate this much pressure? As we learned previously, the opening and closing of small airways and alveoli does not just depend on pressure, but also on time. We also just learned that alveoli are not independent units, they're interconnected. So additional time during inspiration allows the alveoli to nudge their neighboring alveoli open. This is done via pores of Khan, canals of Lambert, and channels of Martin, which link alveoli together. When given enough time and pressure for alveoli to nudge their neighbors open, the alveoli is able to share its volume and pressure with the newly open alveoli, essentially redistributing pressure and lowering the pressure inside individual units. The image above shows how the middle alveoli is able to open the collapsed lung, is able to open the collapsed alveoli beside it and redistribute its volume to them. The microscopic slide on the right shows this even better, where the large alveoli besides the red arrow nudges its neighbor open, and when the new alveoli open, the volume in the original alveoli kind of decreases. This is another image showing that what we saw in the previous slide, which is that additional recruitment of an alveoli decreases the deformation and therefore strain on the initial alveoli because the percent change from inspiration and expiration is reduced. So here it's showing the dynamic strain has decreased. Put another way, as the number of recruited alveoli increase, the volume of each alveoli remains the same, avoiding distension and ventilator-induced lung injury. It seems that recruiting lung and allowing the individual alveoli to share its pressure and volume become important in ARDS. So now let's go over some controversies and myths regarding TCAV APRV. Before I do that though, we must remember something very important. No ventilator mode is safe if the method used to set and adjust that mode is physiologically unsound, including APRV. Even in the ARDSnet protocol, different volume assist control settings, 6 or 12, resulted in significant differences or mortality. In other words, it's not the mode, but the way the mode is set and adjusted that is important for comparison. However, the specific manner by which APRV is managed in various clinical trials is rarely considered in publication, including review articles or meta-analyses, and most of the time, the studies don't even mention what settings have been used to set APRV. The TCAV method, with its T-low being set at 75% and the P-low being set to 0, is the most extensively studied method to set and adjust APRV based on our understanding of dynamic alveolar volume changes in acutely injured lungs. There are numerous basic sciences and clinical publications showing the effectiveness of TCAV by direct visualization at subpleural alveoli in real time, in clinically applicable animal ARDS models, and in statistical analysis of patients in the surgical intensive care units where this mode has been used more often. Other methods to set and adjust APRV mode may not take into account such personalized physiology and may therefore be inaccurately representing APRV-TCAV. So in this case here, all of these methods are APRV, and they'll provide different results based on the setting. And none of them really are set based on what the TCAV says. And in these two studies, they're both comparing APRV, but none of them actually show what settings are used. And different settings will give you different results. So the first myth is that APRV causes barotrauma since changes in pressures are not controlled. To date, there have been no RCTs showing that APRV causes more barotrauma than other ventilator modes. Also, as previously shown, when setting APRV correctly, pressure will actually be physiologically personalized to the lung. The pressure in individual alveoli will also be redistributed to newly recruited neighboring alveoli, therefore decreasing individual alveolus pressure and avoiding trauma created by rapid recruitment, de-recruitment methods. APRV has also been shown to produce the lowest microstrain on distal air spaces and minimize ductal dilation due to its ability to restore alveolar homogeneity. The next myth is that APRV can generate large tidal volumes as lung compliance improves. There have been, again, no clinical studies using APRV that have linked an increase in tidal volume to an increase in mortality. Indeed, as lung compliance improves, a larger tidal volume can be used and change in pressure will actually decrease, since change in pressure equals tidal volume divided by lung compliance. It has been shown in previous studies that a low tidal volume used on a patient with higher lung compliance can actually increase mortality. Let's also not forget that healthy lungs are resistant to overdistension, so as their compliance improves, the risk of volute trauma will actually decrease. The third myth is that the mode is a rescue mode only or as a last-ditch effort mode when ARDS continues to progress despite interventions, which is not true. APRV has been used successfully as an initial ventilation mode in surgical ICU for years, and they have reported improved mortality using this mode. Recent studies have also shown that APRV is a protective approach for lung ventilation and reduces or prevents the progression of ARDS. The lungs in the above picture were subject to acute lung injury and then monitored to see which one of them develops ARDS. As you can see, the late and early groups ended up developing ARDS, whereas the one that was ventilated with APRV stayed pretty healthy. This is another study similar to one shown before. Here they compared a healthy lung, the sham, being ventilated by 5 of PEEP, to 2 acutely injured lungs, each being ventilated with either APRV or low tidal volume. And as you can see, the lungs ventilated via APRV remained almost identical to that of the healthy lung, whereas the one ventilated via the low tidal volume approach progressed to ARDS. The fourth myth is that APRV will cause hypercapnia. Over the past 25 years, it has been shown that patients on the APRV mode had lower PaCO2 levels than those on conventional mechanical ventilation methods when minute ventilation was matched. This suggests that the volume of CO2 removed with each breath is greater with TCAV than with conventional modes. This recent abstract posted in CHEST also shows that there is lower CO2 retention in lungs ventilated via TCAV. The next myth is in regards to hemodynamic compromise while on APRV. It's well known that venous return can be impaired during positive pressure ventilation, but there have been no clinical studies that showed that this occurs more in APRV than other ventilator modes. In fact, a recent study by Lescroat showed no hemodynamic adverse effects observed with TCAV compared to standard protective ventilation, but APRV was more beneficial for the respiratory system. Another study shown here also graphed how APRV had the same, if not better, hemodynamics than those compared to low tidal volume strategies. So as you can see here, they had the APRV lungs had better RAS scores. They also showed required about the same norepi levels. The mean airway pressure was higher. PaO2 was higher. Heart rate was more improved on APRV. The same study also shows that APRV lungs were able to be liberated from the ventilator and were able to breathe without assistance faster than in the low tidal volume group. The next myth is that patients need to be spontaneously breathing for APRV to be effective. Although spontaneous breathing may be facilitated with APRV, it is certainly not a prerequisite. Experimental and clinical data show benefits of APRV without spontaneous breathing. This is because APRV with the TCAV method can prevent or halt the progression of ventilator-induced lung injury and subsequently stabilize the lung. APRV has also been used in brain-dead donors who are obviously not spontaneously breathing. These donors managed with APRV had an 84% higher lung utilization rate than the group being ventilated with low tidal volume. The last myth is a little silly, but there are concerns that APRV-TCAV may be too difficult to use. This suggests that skills necessary to use other modes of ventilation on ARDS patients are much simpler to grasp, which is not true. The skill set may be different, but APRV is not inherently more complex or difficult to use. It does, however, require more time, patience, as well as more attention, since it needs to be periodically adjusted to the changing lung conditions and therefore may require an overall increased effort. Regardless, APRV has been used successfully on tens of thousands of patients for over 30 years and continues to be used today. So the future of APRV looks pretty promising. There is a large randomized controlled clinical trial currently underway being funded in the United Kingdom to test the efficacy of a correctly set APRV-TCAV mode as compared with the ARDSnet low tidal volume strategy. So we can look forward to seeing the results from this study in the near future. Additionally, more training and standardization is needed to protocolize APRV-TCAV, especially in research studies. More studies are also needed to look at long-term outcomes and comparative safety data regarding this mode. A special thanks to Dr. Qtob and Dr. Markandaya for helping with this presentation.
All right, Dr. Khan, I think you did a great job.
Thank you.